Okay, how's it working, Cody?
Rick, you're muted. All right. Bridget, when we're live, I haven't heard back from Robin. I don't know if she's on, but I just texted her. And Bridget, when we're live with YouTube, just give me a shout.
Bridget, I just sent the link to Rob Owens and Karen Labonte, so they should be joining soon.
I'm on now. Thank you.
Okay.
Hey, Karen. Cody's having some technical difficulties.
Hey, Bridget, on my meeting invite, it says the Zoom meeting is 30 minutes. It will not kill us in 30 minutes, right?
Okay, Tom, you should be good to go.
Okay. Did we get Cody on? I think he's having technical difficulties, but we're going to go ahead and start. It's 5:08. I'm going to call to order the June 24th.
Ready, Cody's coming on. Robin just joined.
Okay, we got him. All right. Calling to order the June 24th Southwest Health System meeting. I believe we have a YouTube channel open right now. Do we have any members of the public that were able to join us today? And Bridget, you may be the only one that can see the YouTube presentation. But does not sound like we have any YouTubers that want to join in. If anyone's out there, thanks for joining us. And if we have hospital staff out there,
We're good to go.
just want you to know that we appreciate all the hard work that the hospital staff has been putting in. Not only during these weird times, during the COVID times, but during the normal times as well. So thanks again to the hospital staff. You guys are doing a hell of a job. So great job. Okay, Dean, want to toss it over to you.
Oh, okay. I don't have a whole lot to report. We did get our slate of officers approved on the last meeting. I was voted in as chairman. Bill is vice chair. Rob Dobry is the treasurer. We don't have a whole lot. Other than that, we are short one board member still. We're looking for somebody. So if anybody knows anybody might be interested, please send them my way.
Well, if there's someone who's interested, we're taking them. So
We here, Dean.
What's that?
So we don't share board members, Dean. Sorry.
Well, you know, we can fight over those. Ours is a lot easier board than yours is. So, you know.
Yeah. All right. Well, congratulations, Dean, on being the newest sucker.
Congratulations, or I'm so
Yeah.
sorry. I'm not sure if it's more appropriate.
You must have missed a vote or something. That's how you.
Yeah, I wasn't there that night. So other than that, we didn't have a whole lot other than facilities. And that's kind of, we all know where we are with facilities with the RTU unit in the fall. You guys are working on the OB unit and the chiller. So there's not a whole lot happening there. I don't know. Does anybody have any questions for me on the MCHD side?
Yeah, I think we need to, it probably won't happen this meeting, but we have a couple of new we have Robin being a new board member, and the fact that we haven't really had a good discussion about facilities. I think we probably need to do a primer for our board, just to get them up to speed on some of the projects that need to be done, some of the projects that are in progress right now, and just the cost of those projects. Cody, I don't know, I missed that last facilities meeting. Sorry about that, but Cody, I don't know if you wanted to throw anything in there. I know we have a facilities report later, but while we've got Dean, is there something you want to add?
Yeah, I think as a facilities committee, we wanted to bring a vote to the board for the asbestos testing, which will be the first stage, kind of in the process of, looking forward into the new renovation projects and getting our tier 1 projects completed. So I think that was the big thing, is the asbestos testing in the boiler room. I think, Dean, correct me if I'm wrong.
No,
Too.
no, that's
Yeah.
exactly right. Yeah,
Yeah,
there's
so we need to get the testing done there so we know kind of what we're getting into when we start working on the first big broiler project. We've moved forward on a few things that kind of were in tier 1 that, the hospital and admin's already kind of worked through. The MRI chiller, we have RTU 1 project going up, which thank you to MCHD for the nice donation on that one. That one's went a little bit above what we thought it would, but I think it has to be done, so we don't have a choice. There is a new tier 1. We can send that from a facility standpoint. We can send that out to the board just to kind of see the revised timeline and kind of what we're looking at with the new revisions, because there's been a few things that have kind of moved. Some of them have moved to further tiers. Some have been moved into lower tiers, just so everyone's kind of on the same page about what the immediate project needs are. But that's kind of where we are from a facility standpoint. We will bring the recommendation from the facilities committee to the board tonight to vote on the asbestos testing. They're thinking probably around a $5,000 project to start, but that's really ground zero as far as getting the next projects going, which are on the immediate tier 1 needs. So that's kind of where we are at the moment as far as facilities goes. But we do have a tier, I think it's 1 through 4 at the moment. And so tier 1 being the highest needs, tier 4 being the things that may or may not be a focus, given if we're looking at the old and upgrades on the older side of the building, just kind of deciding what we want to do with that building. Is it going to be an inpatient wing? Is it going to be an outpatient wing? Is it going to house officing, et cetera? So we kind of got to make those decisions with admin as we move forward, but that's neither here nor now. But the big pressing issue would be the asbestos testing to kind of get going, to kind of get some bids on the project to get the broiler replaced. So.
Yeah, there's the boiler and a lot of those steam valves. I know the steam valves are.
Yeah, the steam valves. Yeah.
And when those steam valves get changed out, it's going to be a shutdown for the hospital, basically, because of the nature of the steam and what the hospital needs on the surgery side with the autoclave and all that other stuff, heating. So that's going to be a big coordination with the hospital, with that SHS. So
Yes.
once we get all that dialed in from SSR, we will be able to probably try to get that scheduled. And along with, we probably need to be thinking about another RTU replacement. RTU 2, I'm assuming, is probably next on the list a year from
Yeah, I
now.
think that's pretty high on the tier. Yeah.
Yeah. And with the border issue. So anyway, yeah, I don't think I have a whole lot, unless there's any more questions for me. I don't think I have much more.
One quick question. Did we decide on a July 14th facilities meeting again, or is that tentative?
I think that went out today. A recommendation on the date. My last email, let me look. looked like it was, one second. Bridget, can you chime in on that one?
Yeah, hang on. I can do the 14th at 4:30 if that works for you, Cody, 4 or 4:30.
The 14th at 4:30, pulling up my schedule now, 14th. I am probably going to be covering in Durango that day, but I should be able to be available of either, in person or on call. So that shouldn't be a problem.
I will schedule it.
Perfect.
4:30, okay.
4:30.
Live.
Dean, does that work?
Will you send an invite out, Bridget? So,
Absolutely.
okay, perfect.
Does that work for you,
Bridget.
Tom?
Yep, yeah, it's on my calendar.
Okay. Dean, you good with the 14th, 4:30?
Yep, that works.
Cool.
Yep.
All right.
All right,
Perfect.
Dean.
Perfect.
Any
Anybody
questions?
have questions for Dean on the board or
I have-
facilities committee?
I have one question, and I don't know whether it's for Dean, Rob, or who. So what's up with the wall in the parking lot? Did it just cave off or what? What's up?
We had a lady drive through it.
Yeah, it got hit.
Wow,
It-
that wall got hit? How did
Yeah.
they hit that?
Well, she's an old lady, I think,
Careful.
Careful
That's
there,
all I
Cody.
said. I said nothing.
We're all old. We're all old.
I think she was about Tony's age. So,
And she was-
you
Good
gotta,
lady.
understandable,
She was
She was
also,
apparently hit her accelerator instead of her brake and went into the wall and knocked it down. Yeah.
easily confused.
and I heard she was under the care of Dr. Burke. So
Yeah,
there you
yeah.
go. Okay.
I think that is
Recently anesthetized. Yes, it was perfect.
You do good work. Good way to drum up some additional work, additional business.
I want to keep MCHD on their toes. That's my goal.
Yeah, you're good at that, Cody. So I believe it's in process with the insurance company. And then I believe that none has looked at doing those repairs. So at that point, I have not talked with Ralph or Rob to see where we are with that, but it's in process. So as soon as we get that back, I'm sure it'll be replaced.
Okay.
through
Dean?
the-
I'm sorry. Go ahead.
Yeah, that's all I had.
Any updates on the MBI?
So we're still waiting to hear back from that users association. I expect that at this point, it'll be a fall project
Cool.
to try to get that in this fall for next spring. We haven't heard back from the principals on that about when they're having a meeting. We've basically approved to do the project once we get approval from that users association to access that pipeline. So once we get that access into that, it's going to be a matter of writing a check and doing the dirt work to get the line in. So I would expect that we would probably
Yeah,
see
you guys are
something
good on
happen
the
in
check
fall.
stuff, so that's good.
Well, we'll see. we're starting to run thin, so we'll see what happens on our tax base, what we get back this year. But yeah, we've kind of got that allocated and planned out in our budget. So once we get approval that we can access the pipeline, we'll buy the water shares and we'll get some bids to get that dirt work done. So hopefully it'll be good for next spring and you guys can save, a bunch of money and we'll have irrigation. So,
Cool. Thank you.
yeah.
Okay,
You bet.
thank you, Dean. Anything else? Okay,
Nothing for me. If you're done with me, I'm going to go eat some dinner.
All
Nice.
right, good.
Congrats on your appointment to the board or the
Yeah.
chair of the board.
yep, appreciate it.
Thank
Appreciate your help.
you.
All right,
buddy.
All right.
Bye.
Thanks.
Oh,
Uh,
okay, so we do have the audit, that's down with the financial committee section, but I wonder if we want to get Blue out the door since they've joined us. That way they don't have to join us for the whole meeting. So I propose that we move the Blue and Company audit report up the agenda and just have them start right now. Any issues with that, anyone? Okay.
No.
Tom, how long do you think the audit report will be? I have Beth Kim on the line, and I just wanted to get her off as well. She's got about a 5-minute presentation, if that's acceptable to everybody.
let's do her first then.
Okay, thanks, Tom.
Thanks, Dave.
Again, Beth Kim is our Vice President of Revenue Integrity, and one of the things she's working on is price transparency and providing that education to the board. This is a pretty important issue for us from a hospital standpoint, so the timing on this is good. But Beth, I'll turn it over to you for a brief overview.
Great. Well, good evening, everybody. I know this has been in the news a lot, so I'm assuming everyone's kind of heard about it. And about a year ago, we also presented on this, but it was really the old price transparency rule, and really kind of just talking about what was being proposed. And now this is actually the final rule. So I wanted to go over kind of the details about this and just the mandate itself. So if you have the slide deck in front of you, just in terms of the agenda, really briefly, we're going to go over the current regulation that's in place, remind everybody about that. We'll talk about what happened this year in terms of an update, and then we'll talk about the 2021 regulation and the two main requirements that go along with that. And then hot off the press, I'm sure some of you got emails about it today, but we have kind of some information on the current status of the ruling and some lawsuits that are involved. And then finally, we'll talk about how we can prepare. So I promise to keep it short, but wanted to get through some basic information. Sorry?
Beth, if you want to just tell me to go to the next page, I have it up on the screen for everyone.
Perfect, thank you. So on slide 3, just to touch upon the January 2019 regulation, that is the one that's currently in place. It came about, this is when price transparency first became kind of the buzzword, and that was in August of 2018. And so that went into effect on January 1st, 2019. So I'm sure you probably remember this is when CMS required that all hospitals publish on their website a list of standard charges for their hospital. So this includes every service you provide, every supply, every drug, basically everything in your charge master, along with the gross charge. So what the gross charge is, of course, it's what is billed to the patient or billed to the insurance company. It is definitely not what the patient ends up paying. So really, it wasn't very useful to the general public, but that's what the requirement was. The second requirement was, it wasn't as publicized, but it was making public a list of standard charges per DRG, the diagnosis related group. So basically, kind of the average charges on the inpatient side per DRG, and so that should be out there as well. There were no penalties at the time or currently. So I know a lot of hospitals really didn't. They just decided not to publish anything out there because they knew that there wasn't going to be a monetary penalty. Although they were out of compliance, and all the CHC hospitals, of course, we wanted to be in compliance, so we were able to post both of those out there. Just in terms of what happened after that, we did see a little bit of traffic when everything was first posted in January. I think a lot of it was insurance companies and consulting firms kind of snooping around and looking at other people's pricing, or even other hospitals looking at other hospital pricing. There wasn't too many patient requests or patient inquiries on that. So after the first couple of months, I kind of checked in with all the hospitals recently, and really for the past year, there's been very, very little traffic on the website for that particular, for those particular files. So on the next slide, this year we kind of got off easy. There was no new regulation that was put in place. However, going back to the 2019 regulation, part of that was to update your price list every year. So, a lot of hospitals do it annually, do it monthly. Some do it every time they make a change to the charge master, but at least annually it needs to be updated. So that's the only thing we had to do this year or this January. So on the next slide is what I wanted to talk about mostly. The final rule came out and it was specific to price transparency, which is kind of unique in that it was just for that specific topic. And the regulation is set to go into effect on January 1st of this coming year of 2021. So there are two main requirements. There are a lot of other details about this. I mean, CMS gave a hour-and-a-half presentation about the ins and outs of this rule, but just to kind of summarize it for you all, the first requirement is to put on the website something similar to what we have out there right now, but a lot more detailed. So what they want is a list of every service item and supply that you have, so essentially your charge master, with your gross charge, which is already out there. So we have one of those 5 standard charges covered. Now we have to work with the other 4. So the next thing that we need for each of those line items. So I think I checked your charge master. I mean, for critical access hospitals, around 4,000 to 5,000 line items in the charge master. So for each of those, we need to also now put the discounted cash price. So if you're a self-pay patient and paying cash, how much would that discounted cash price be for every single one of those 4,000 to 5,000 line items? In addition, and this is the hard part, we have to now post out there the payer-specific negotiated rate. So if you have 40 different contracts with, different payers and plans, and that's kind of on the low side, the average or low side, each of those, for each of those 4,000 or 5,000 line items, we have to have that negotiated rate plugged in there. So if you really think about that, if it was a very straightforward contract, which I bet none of your contracts are this straightforward, where it said, okay, we're going to pay you 80% of charge for every single line item, then that would be pretty easy to put out there. But as you probably know, contracts are a lot more complicated than that. It has different fee schedules, per diem, stop loss, different caps and things like that. And so to kind of boil everything down that's in that contract into, a file with, one cell, it's very difficult to do. And we have to do that for every single line item in the charge master, for every single payer, for every single plan. So now this file that used to be 5,000 rows and 2 columns is now going to be however many contracts you have and however many payers and plans you have. That's how many columns it'll now have. The other thing we need to include is a minimum and maximum negotiated charge. So for that particular service, let's say we're talking about an MRI of the foot, we have to now say which payer, it's de-identified, so you don't have to say which payer, but you have to post the lowest negotiated rate and the highest negotiated rate. So any payer can come on and see, okay, well, I'm not the lowest negotiated rate, so I have some wiggle room to do contracting with. So again, it's very, exposing a lot of information out to the public. So, and then on top of that, if that wasn't enough, we now have to include services of employed physicians. So if you have any employed physicians, we need to now in that file include the professional fees and all of that associated information with that. So if you think about it, it's just a very daunting task to put together, a file of that size, and also to pull in all that contract information and interpret it to put it into a spreadsheet like that. So that's the first requirement. The second requirement is, I think of it as a subset of the first one. Once you have the first one done, which is a huge undertaking, the second one's pretty easy, but it's a list of shoppable services, and CMS is defining that as something that can be scheduled in advance. So radiological procedures, lab tests, those types of things. CMS is telling us, here are the 70 that you have to have in that file, and then hospital, it's up to you to add 230 other services to make a total of 300, and have all of that information available as well. So the one thing about that second requirement, and I will clarify if this only covers the second requirement, is if you have a web-based price estimator tool, or if you purchase one in advance, and it has to meet certain requirements, but that will cover that second bullet. I think there's a misnomer out there. I think a lot of vendors are saying, hey, buy our tool and you'll be compliant with the CMS price transparency guidelines. And that's not necessarily true. You're compliant with the second requirement. You still need to cover the first. And then the last thing I'll say is, before there was no penalty, and now there's going to be a $300 per day penalty for noncompliance. A lot of the bigger hospitals might be able to get away with just assuming the penalty and not doing the abiding by the requirements, but, we just really don't have that luxury. $300 per day adds up pretty quick. So we need to really make sure that we abide by all the requirements of this mandate. And so we have 6 months to do so. All right, if you turn to the next slide, there was some hope. I had some hope because like all of us probably in the room, as well as, physician groups, hospitals, insurance companies, everyone was against this, just because it didn't really make a lot of sense. It's not really useful to the public, and it's just a lot of work. And so the AHA and some other provider groups got together and they filed a lawsuit against this to overturn it, and they filed it right after the final rule. So this was in December of 2019. And there were hearings that were supposed to happen in early 2020, but of course, COVID hit at that time. And I thought the one good thing that might come out of COVID is it would kind of make this go away, or at least delay this for a while, but it actually worked against us in that it delayed all of the hearings and all of that. So they didn't have a hearing until May of this year, May 7th of 2020. And that's when they heard all the oral arguments. And the providers did present arguments saying, hey, this is going to be a huge burden on the hospitals who are already strapped for resources because of COVID. Please let's either delay it or overturn it. So you may have seen in your email inbox today or seen in the headlines today, but as of yesterday afternoon, the federal judge sided with HHS and actually ruled against the providers. So they ruled against the lawsuit. They also rejected all of the arguments included in it. So they, the one suggesting that's a huge administrative burden, they rejected all of that. And so, so the AHA is appealing. They're trying to do an expedited appeal, but, given that we only have 6 months left, we're still in the thick of COVID. So who knows how long that appeal will be delayed. And, I don't hold out much hope that it's going to get overturned in this second pass. So sorry that the slide is not up to date. That's just, we just heard about that this morning, but that is kind of where we stand right now. So that leads us to our last slide. Since it doesn't look like it's going away, how can we prepare? We were really excited at the beginning of the year because we had a really proactive approach to everything. We created a task force at the beginning of the year with hospital representation. Rick is actually on that task force, and with some of our representatives from legal, IT, we had a whole team working on it. We developed templates that could help hospitals do this manually or assist in the contract, to turn that into spreadsheets and all of that. But then COVID hit again, and it really pushed everything back, of course, and reprioritized everything. And now, since we only have 6 months left, what we're doing is we're looking into vendors that can help with a solution. Just from a time perspective, it just really helps to kind of get some help. And so, like I said, we are having trouble finding vendors that really meet the requirements that are laid out. And we've talked directly with CMS, so we are very clear as to what the requirements are. But we do have several vendors that do meet the requirements. And are at a price point that should work for our hospitals. So we're just kind of finalizing some things there. And then what we hope to do in the next couple of weeks is really work with each hospital individually and kind of present some options. Of course, any hospital can go about it themselves, but really, we want to at least offer, some vendor help or some, CHC help, or kind of work and kind of figure out the best solution for each hospital to meet the deadline. So that is really all I have. I know I didn't bring the best news tonight, but are there any questions?
Yeah, Beth, this is Tom Rice. You mentioned earlier that it was a daunting task. When this stuff is posted, is there a primer for any of our customers to take a look at so they understand what they are actually reading, negotiated prices, different levels of pricing? How do we get this message to our patients clearly?
Yeah, that's a good question. I think, we can put out as much as we possibly can in terms of education. And that's what a lot of people did, even with this current regulation in place, to try to educate the patient on what exactly they're looking at. From my personal perspective, this rule is not only an administrative burden, but it really doesn't give the patient a lot of good information either. I think it's going to be extremely confusing to the patient. And when you really think about it, even if they're looking at the negotiated rate between the hospital and the payer, that really doesn't have anything to do with what they're going to pay, because it doesn't take into account any co-pays, deductibles, anything specific to the patient. So I personally, we have to meet the requirement, but I don't think it's going to bring about a lot of clarity to the patient. I do think you're right. We need to do as much as we can to provide education. I think on the website's a great option. But it's confusing to those of us in healthcare, honestly. And so it's very hard for a consumer to figure out.
Be interested to see if we could use it as a marketing tool. You know, our hips are better than Mercy and they cost less. You know, so, yeah. But
I will say one. Yeah, I will kind of wrap up with this. I will say that the one good thing that's coming out of this is, you know, if the hospital chooses to go with a vendor route, a lot of the vendors, of course, they're going to use or they have a price estimator tool developed for the website to meet the regulation, but also that, you know, a lot of them come with the additional, you know, information where the patient is able to put in their specific plan and their specific information and get to that actual number, you know, where they have, you know, it does take into account their copay and co-insurance and all of that. So, you know, that is one good thing that might come out of this is more hospitals will lean towards using those estimators. And I think that if it's done correctly, could potentially help the patient that way.
Okay, very good. Any other questions, or Beth, anything else to add, or any questions, Beth? Okay.
I appreciate it. Thank you.
Thank you. Appreciate your hard work. Okay. Do we want to bump over to Blue and Company and discuss the audit, or does that work with everyone? Looks like we have it up on the screen. So let's go with Blue and Company.
Okay, thank you very much. This is Steve Jones. I have with me Mark Daffer. Mark was the manager on your account, did all the hard work and heavy lifting, and I served as the audit partner, so I had the easier of the two jobs. But we're both here. We talked with the finance committee last week in draft form of these financial statements and the management comment letter. And what I wanted to mention is now it's in final form. As you can see, we were waiting on an attorney letter, and we are required to receive those just in case there is something that the attorneys know that would need to be disclosed or accrued in the financial statements. And so we were waiting on that last bit of information so that we could issue the final financial statements. But I'm going to go through this in a little bit more brief summary than I did with the finance committee. We talked about it in detail, but certainly if anyone has any questions, just stop me. I'll be glad to answer any questions that you would have. But in looking at these financial statements, it's going to be clear to you that you've had such a fantastic turnaround year when you look at the prior year to the current year. But we're going to start in the financial statements with the opinion on pages 1 and then continued on to page 2. And because you had a strong year this year in comparison to the prior year, we were able to issue an unmodified opinion, which is also known as a clean opinion. That's the one that you want to receive. And you did receive that this year. But on page 2 of most significance was that at the very bottom of page 2 is change in accounting principle. And part of that talks about that there was a couple of new accounting standards we were required to implement on your behalf this year. One had basically no impact, and that was clarification of contributions. The other was revenue with contracts, and it's revenue recognition, better known as revenue recognition. That one did have a significant impact on your financial statements, and we will go through that in detail as we go through the financial statements. But I don't know if everyone can see on page 3, starting at the balance sheets.
We are having some issues with seeing that PDF. At least I am.
Okay.
Bridget's working on it.
Sorry.
All right.
I'm having trouble with Adobe. It keeps making all my PDFs blank. Here we go. Is that better?
Yeah.
That's better.
Steve, can you see the assets and balance sheet?
I can see it now. Yes.
Okay.
Sorry.
So on this page, this is page 3, total assets. So this is a snapshot at year end of your total assets in 2019 compared to 2018. You actually had a decrease in your total assets of $3.3 million or 5.3%. But when you look at what made that up, your current assets, halfway down the page, total current assets increased 2.2 million. The most significant part of that increase was the increase in cash. So you went from $1.2 million to over $4 million in cash and cash equivalents. And I'm going to sound like a broken record to a certain extent. And that is because management has implemented a lot of revenue cycle initiatives, and we're starting to see the major positive impact that's had on the financial statements. it's shown a reduction in your patient accounts receivable, which also helped to increase that cash. You also had about a $511,000 increase in your assets as uses limited. Those are your investments. And the biggest decrease and what drove most all of the total decrease in total assets was your property and equipment. With your large construction project being completed and that coming on board, we had a lot of depreciation expense, much higher than in the previous year. And so therefore, property and equipment as a whole decreased. Now on the next page, page 4, looking at your liabilities and net assets. I don't know if you can scroll down, Bridget, there. One page. There we go. Your total current liabilities decreased $452,000. Total liabilities themselves decreased $2.7 million, with the largest part of that being your long-term debt. And your long-term debt only decreased because of your scheduled principal payments. So there's nothing irregular there. Those are your scheduled payments. And your net assets without donor restrictions, that's your equity position, decreased $633,000. We'll want to talk about that in detail here in just a little bit. But that is without restrictions. So that's your equity position. It's basically unrestricted, if you will. On the next page, your statements of operations infuse the word income statement, if that's easier for you, those that are used to that terminology. Total operating revenues, this is where we see the biggest part of the turnaround. Your turnaround, you increased $6.5 million in operating revenues in 1 year. That's 12.1%. That's very significant. And in looking at this, one of the questions that came up in the Finance Committee, as you're all looking at the screen, if you look at 2018 compared to 2019, it looks like we've just got some blank space above 2019. This is not an error. This was purposeful. This is a part of the change of the revenue recognition standard that we were talking about. So going forward from 2019, when we get to 2020 and we compare 20 and 19, it will look just like it does in the 2019 column. What they've changed in the standard was to get rid of the provision for bad debts as part of the revenues. It's called something different now. It's called an implicit discount. And they want the reporting to show at the net patient service revenue level to start with. So that's the reason for that. It's not an error. It's done purposefully. Old way in 2018, new standard in 2019. But in looking at your operating revenues, $5 million increase was net patient service revenue year over year. That's very significant. Again, improved cash collections and revenue cycle initiatives that were put in place by management. Other revenues, again, a very significant increase, $1.8 million. That has mostly to do with you increasing your 340B program, and that has been beneficial for you. And then looking at operating expenses as a whole, so we had $6.5 million of increase in revenues, but we only had $1.1 million increase in expenses. So again.
Quick question. 340B is the pharmacy program, is that correct?
That's correct.
Okay,
so,
thank you.
Yes, so you're benefiting from being involved in that 340B program. I know in talking with management and of course some of the board members as we were conducting fraud interviews, I know you had to make some tough decisions, and that shows up in salaries, wages, and benefits. I know those are never easy decisions, but it has benefited your organization. You've definitely going in the right direction when it comes to that, to right sizing, if you will. And so your total operating expenses increased actually only a couple $100,000 from year over year. So the loss from operations, we did end the year with a $2 million loss, or just shy of a $2 million loss. Again, that's down significantly from $8.2 million loss in 2018. So there's still some work to be done, but you have made great strides from 2018 to 2019. Non-operating revenues, your non-operating revenues, you ended the year with 2.2 million of those. That's an increase of 500,000. So you actually ended the year, it says excess revenues or expenses, insert the word net income. Your net income for the year, you actually had a net income of 278,000. That's compared with a $6.5 million loss in the previous year. I've not seen a turnaround quite this significant for a hospital your size in 1 year. So you're definitely making good strides. Congratulations on a good start to the turnaround. Now on the very next page, page 6, statements of changes in net assets. The thing I wanted to highlight here that we talked about with the Finance Committee in detail is about halfway down the page, you'll see the words cumulative effect of change in accounting principle, and you'll see brackets around $911,733. So what I wanted to explain there is the revenue recognition standard changed the way we recognize revenue. It changes the way we're looking at bad debt versus implicit discounts. And through changing of the rules and the revenue recognition standard, when we looked, we are required to look at the previous year end to determine what impact had the new standards been in place at the end of last year, how would things look and how would they be different? And if it's significant, to post the cumulative effect directly to equity. And that's what that number represents. It's saying that this standard negatively impacted you by $912,000. And so it's taken directly to equity versus running through the income statement. So they allowed for that treatment that was purposeful and appropriate. And so that's what that represents. It's a change in the rules, if you will. Now, the next page, on page 7, the statements of cash flows. Again, we talked with the Finance Committee about one of the biggest changes is that halfway down the page, you'll see net cash flows from operating activities. Look what changes happened from 18 to 19. Your operations actually used cash last year of almost 120,000. Yet in 2019, with all of the progress that you've made, your operations produced positive cash flow of $3.6 million. Again, that's a very significant and positive change. Investing activities, you produced cash flow from investing activities this year of $1.2 million compared to usage of cash last year of $8.2 million. Of course, last year that was planned. That has to do with your construction and what happened there. So that was a planned use of cash. And then in your financing activities, all we were doing in 2019 was paying down our scheduled principal payments, again, about $2 million. So you ended the year with a positive change in cash and cash equivalents, an increase in cash of $2.8 million. Now, starting on page 8 are the notes to the financial statements. I'm not going to go through these in detail. I just want to highlight some of the more significant items relating to this change in accounting principle. And if you will, we're going to start on several pages down. We're going to start in the back towards on page number, let me get to it. We're going to start on page 23, but quickly go to page 24. So that's footnote number 9, net patient service revenue.
Bridget, I think it's like page 26. So whatever Steve said, add 3 pages to it.
Oh, sorry, Bridget. I'm going off the financial statement page number, not the PDF number. Right there. That's perfect. So on that page, you'll see the table. This is a new table that you would not have seen in your prior year's financial statements. It's something new with this revenue recognition. And this entire footnote, if you compare last year's financial statement with this year's financial statement, you'll see this is a great expansion of your net patient service revenue footnote. It's a required change by the new standard. They're highlighting areas that are significant so that the readers of your financial statements have a clear picture of what drives your revenue and what it looks like. In this particular table, what was most interesting in looking at this comparison year over year was we're looking, and this is a snapshot of the year's revenues earned from a net patient perspective, not gross, net revenues. And so what was interesting to us, you saw back on the income statement, we had such a large increase. And you can see in this table, $5 million increase in net patient service revenue. Well, typically when we see that, either volumes have greatly increased or there's been a very favorable change in your payer mix. Well, in looking at yours, you actually had an increase in Medicaid and a very large increase in Medicare. those two typically don't necessarily always equate to a good positive change in your payer mix. A good positive change in your payer mix usually is driven by an increase in your commercial, but your commercial actually decreased. So in a lot of ways, you were swimming upstream against a declining, more negative payer mix, and it's turned out to your advantage because of all the revenue cycle initiatives that have put into place. So, congratulations on working through that. Usually when we see this kind of change, it has a negative impact on your financial statements.
So quick question here, is that
Yes.
increase in the Medicare and Medicaid due, and Rick may answer this too, due to that Medicare crosswalk that we initiated back in 19, was that right? Where basically where we would, if one program wasn't paying, we would go to the other. Is that why we see that increase, and we didn't do that before?
No, sir. You'll see that a little bit in some of the Medicare cost report. But the issue is if you look at the prior financial operations, and what he's talking about, Steve, is not claiming the Medicaid crossovers as part of bad debt. Is that what you were asking, Tom?
Yes. Thank you for clarifying what I was asking.
So part of that was the Medicaid crossovers for bad debt, because Colorado really doesn't reimburse you. They say, claim it on your cost report, and then get 65 cents on the dollar in 2019. So that, you're seeing a little bit of that translate into some of the Medicare, but not necessarily the Medicaid. And
Okay.
some of the crossovers we may have found, Tom, may have been $400,000.
Okay.
So it's
Minor.
a little bit, but the other $6 million was, just Medicare beneficiaries coming to our facility.
And then how do we recapture, and rather than swimming upstream, as Steve put it, maybe get up on plane and go downstream and get more of that commercial managed care cash flow coming in? Or is that just cyclical and out of our control?
Well, part of that is kind of working through, looking and having better partner relationships, being in a tier 1 status with some of our community employers. And that's something that they've asked for. So we're working through that with the city and the county to basically, to address things that we can't hear. The reason we can do that and have those discussions with the county and the city and, Dolores County and other counties, based on the fact that Tony and Carrie have kind of expanded the bandwidth of our providers, and it's bringing in an additional orthopod, and it's bringing in additional primary care physicians, internists like Charlotte Berry and Susan Lanningham, and bringing in other nurse practitioners and PAs and things like that. So that's all the strategy plan that Tony and CHC laid out of how to build and expand the bandwidth of the provider network to where increase accessibility, to said providers. If that answers your question.
Yes, thank you.
Okay, if we can go to the very next page, at the very top of page 25 of the financial statements, service lines. This is an additional footnote disclosure that you would not have seen in your previous year's financial statements. What this is attempting to do is let the readers of your financial statements better understand what service lines are driving your revenue streams. And so you can see your inpatient actually had an increase this last year. Many of those we see either it's completely flat or maybe a slight decline, but your biggest growth area was in the outpatient area, slight decrease in your clinical, and then also ambulance. So you can see some of the shifts between 2018 and 2019. And the last thing I wanted to cover on the financial statements themselves, if you would turn to the very last page of the financial statements, page 32, footnote number 19.
It'll be page 34.
There we go, right there. new accounting standards coming forward. The lease standard, this one has been I think I've been talking to boards about this for probably 8 or 9 years. And this was the FASB's attempt to get with international accounting standards. They thought, you know what, United States generally accepted accounting principles, US GAAP, is just different than the rest of the world. The rest of the world is on IFRS, which is international standards. And they wanted to say, is there some way, because we're such a global economy now, is there some way we can come together and find some common ground on some standards? So they thought, we're going to start with leases. Well, like I said, that was 8 or 9 years ago. It's taken this long to finally come up with something. And at the end, the United States just did something a little different than international standards. They got closer, but they certainly did not adopt what IFRS had. And so this was the United States attempt. And in spending so many years going through this and having battles between international and United States standards, they decided to kind of pump the brakes, and they're not planning to do anything in the future. So that kind of tells you that there wasn't a lot of common agreement between international and United States standards. But this lease standard for you is going to, it could possibly have some major impact to your financial statements. The good news for you, it's been extended a couple times, and most recently for COVID. And so the financial statement year end for you that it will be applicable is December 31st, 2022. So we've still got a couple of years before this comes into play. Basically what it's telling you is every lease that you have currently under current standards, you have operating leases that only show up in your income statement as rent expense. And then you have capital leases that show up as an asset and a liability on your balance sheet. And then the income statement impact is interest and depreciation expense. What this standard is telling us is going forward, when this is applicable, all of your leases will show up as debt on your balance sheet. So that's the significant change. They're all going to be basically treated as capital leases going forward. But again, that will not be effective for you till 2022.
Well,
and with that, go ahead.
Explain to me how did we capture those leases, because those are expenditures. How explain to me again, and I'm sorry if I missed it, how we captured those expenditures.
So underneath the current standards, if you had a capital lease, and there are 4 criteria to distinguish between an operating lease and a capital lease. A capital lease basically shows up as a liability and as an asset. So the asset would show up in your property and equipment, and the liability would show up as a capital lease liability. And then as you make payments, you depreciate the asset. So that's where the depreciation expense shows up. And when you pay down the principal, there's an interest component of the lease liability, and the interest expense shows up in your income statement. The operating leases, those typically you make a payment, you credit cash and you debit rent expense. So there's criteria between those. Going forward, and the best example I've been giving to boards that, because they're saying, really, Steve, are we really going to have to take every lease? It doesn't make sense. We may be leasing a building that we've been leasing for some time that someone else owns, and we will never own this. So tell me again how this new standard is making me put an asset on my books for something I don't own. And the answer is they came to some compromise. They want you to report the liability so that the readers of your financial statements have a better indication of the cash flow of future payments. And so instead of an existing asset, they're going to call it something like a right of use asset. So that'll be clear to the readers of your financial statements that it's not something you own. Some of those you may own, but many of these, like leasing a building off-site, off-campus that someone else owns, it may just be a right of use asset that shows up on your balance sheet.
To kind of answer that point, kind of piggyback on what Steve said, we have 4 right of use asset schedules by Celtic Leasing. One we're going to take out at the end of this year on 12/31 or a little bit before that. And then the other ones mature in, I believe, March or April of 2022. So our goal is to go through and either basically buy ourselves out of the leases. And they're not great. And we need to go ahead and get ourselves out of that. So what Steve's talking about may not impact us because we will have addressed it in March. And where Steve and Mark are going to take the position is what it was as of 12/31. So if we get everything fixed by April 1st of 2022, you won't see that having to be reported. Is that fair, Steve?
I think so. Any other questions on that lease standard? If not, that's what I had to present. We appreciate the opportunity to serve your organization. First year audits are always more comprehensive because we're getting to know you, you're getting to know us. As a board, I think it's important for you to understand we were given every opportunity to review everything we asked for. We received the documentation. We appreciated all the hard work that your folks put in. And with that, I'll open it up for any additional questions you may have.
I know that we have some YouTubers on. Any questions from the public about this this audit? You can use the chat box, obviously. I don't hear Bridget. I don't think anything's coming in. Any questions from the board?
Yeah, I'll let you know if I see a chat for you, Tom.
Any questions from the board? Well, and Steve,
I got a little, yeah, I'd like to, how rare in your experience in auditing to see a turnaround like SHS has done in a year?
It's pretty rare. We've seen some turnarounds, but for a hospital your size, and I'm talking about dollar amount. So when I look at your total revenues and total assets compared to the turnaround that you've had in 1 year, that's pretty unusual to make that significant of an impact in just one fiscal year. You usually will see, someone might make a 15, 20% turnaround in year one, and it takes 3-4 years to really get to where they want to go because hard decisions need to be made. And sometimes even the revenue cycle initiatives that you put in place, sometimes it takes a while for those to kick in. But this one has been significant. So congratulations. I know that's not easy to do. I know there's still work to be done, but to do all that in 1 year, you're definitely on the right trend line.
well, there certainly were hard decisions to be made. It was difficult on the community and families as well. But those decisions had to be made. And, I think this audit affirms some of the good work that we've seen over the year. And I'm glad that it's interesting to hear you, Steve, discuss how this is an unusual turnaround. So that speaks highly of some of the leadership and the hard work that's been done by the C-suite. So well done, everyone.
Thank you. Thank you very much.
Yeah. Steve, appreciate you all coming up from the southeast to the southwest. It's always good to see some folks from the other side of the country here.
It's been our pleasure. Thanks so much.
All right, Rick, we're glad you're back from that other side of the country too.
Thank you. Thanks, Tom. Thanks, Steve and Mark.
Well done,
thank
Steve.
you.
Thank you, Mark.
Thanks.
Thanks,
Bye-bye.
Steve. See you, Mark.
Bye.
Okay.
Thanks.
All right, well, let's bump back to CHC's monthly update. Craig, if you're ready to do that.
Yeah, Tom, really, for the sake of time, my report is as written. I mean, our focus has really been with Rick and Tony and the team on COVID activities and making sure looking at the cash that's been received from the various entities, monitoring that, as well as working with the team on the accounting of that. We have internally an internal auditor that will be coming out to all our facilities to work with the hospitals to ensure that they are compliant with all of the rules and regulations that are continuing to change in regards to forgiveness of the loan amounts and such as well. But again, I wanted to spend the most of the time just for the board to hear about the pricing transparency, since that is a recent development and will have a significant impact on all the hospitals as they prepare for that for January. Finally, again, just want to echo from the audit standpoint, again, congratulations to Tony and to Rick and the team and the turnaround success and the evidence that is continuing to be made in there. And we appreciate all of their efforts as well from CHC and the work that they've done too. So that's really my report, Tom, unless there's any questions I can answer for the board.
No, but to the board, you know, I did talk to Craig earlier this morning just to chat about how things are going. And it's good to know that Southwest Health Systems and the hospital are, you know, doing a hell of a job in this challenging time. Also, just compared to a lot of other hospitals that are out there, you know, trying to struggle through this crazy, challenging situation. And the fact that a rural hospital like ours remains open is pretty damn important to our community. And again, we're pretty lucky to be open still, and appreciate that leadership that y'all are getting there. So anyway, kudos to you guys and the deep bench you have there. Yep. I just want the board to understand, you know, where we are in this broader scheme of other hospitals and how they're operating in this COVID environment. So, all right. Any other questions for Craig? Okay. I know we bumped around in the financials. We'll have to go back to financials after we have Carrie join us, or I'm sorry, have Karen join us. Or who's going first? I guess Carrie or Karen, or how do you want to handle that?
I think the first thing is the COVID update.
Oh, I'm sorry. Yeah. And is Carrie doing that, or Tony, are you doing that one?
I think it's going to be a team effort.
Okay, go team.
Yeah, I believe.
I'm sorry, I
Bridget's
couldn't
got
get off
a-
mute. I apologize.
I believe Bridget's got a summary that she's going to put up there. I think. There we go. Yeah, I think that's a very true statement right there. You know, you wake up every day and figure out what's the new day going to break this year. It's just been pretty amazing. Like I said, I've said several times in my CEO reports, I think we have been very fortunate as an organization, and I don't think it's totally by accident. I think a lot of it is that we did have our house in order when this thing hit. And I've also said a couple times, I would hate to have seen what happened if this happened back in 2018 instead of 2020. I don't think we would have probably come out the same way, but we continue to, you know, kind of move things a little bit back to normal, still in a very cautious manner. We were talking today that you know, we want to continue to be the example for the community. So we don't expect that we're going to let up on a lot of the things that we've been doing as far as the precautions that we're taking within the hospital. But at the same time, we are starting to see our volumes come back. We're starting to finally see some increases on the inpatient side. ER's coming back a little bit. Surgery's been very strong, very busy. So we're starting to see those happen. And again, some of the other efforts that I'll let Karen and Carrie talk about as far as what we're doing. But just overall, like it's just a gradual move back to, you know, to a more normal situation. And unfortunately, I think it's probably what's going to be the normal for a long time to come. But at least it's starting to get back to a little bit there anyway. But Carrie, you want to tell us what else we have going on now?
So I think one of the things that we changed here recently, and it ties into what Carrie's been doing through the drive-through, is that we do testing on our patients that are getting procedures done. So OR, sleep lab, and pulmonary function test. And now that we have the BD Max, we really are scheduling those patients the day before, which gives them a closer time from the time that they get the test and the procedures done. And so we have a new process for that. They're actually coming back up and going through the front door to get that test done. So that's been an improvement. You know, we're really looking at the visitor policy for July. That will be coming soon to see how we're going to change that, as well as, you know, what we're going to do about the kitchen. There's quite a few things that we're kind of putting back to somewhat normal from before. We also, at this time, we had a lot of the dentists in the area give us all of the products that they had that they were not using because they were closed down. So we've been working with them to reprocess their N95 masks, because we do have a process for that, and just to help them out with that piece, since they were helpful to us at the beginning.
Okay, so there's a few updates as far as
COVID that we can talk about. One is the drive-through. We did move to the Monday, Wednesday, Friday, like it says up there on your screen, 8 to 2. We will continue to adjust as needed, but we're currently seeing between 50 and 70 patients coming through that drive-through a week. So we're still pretty busy as far as needing a provider and seeing the community at this time. So remember that we're not just doing screening testing. So this is not somebody that's asymptomatic or somebody that hasn't had an exposure. So the two criteria, really, there's several criteria, but two of the things that I want to bring to the board as a point is we are doing this testing for symptomatic individuals. So people that are having symptoms, and the other group that we're testing, or there are 3 groups. So the other group that we're testing are people who have been exposed to somebody with known COVID. So, somebody at their workplace, somebody who lives with somebody who was diagnosed with COVID. So those people we're testing, and then we're also testing travelers. So there are several states, including Alaska, that are requiring once people land in the state that they have to have a negative COVID test within 72 hours. So last week alone, we did 11 tests for the community for Alaska particularly. So we are testing those individuals as well. So that's an update on the drive-through. We will continue the drive-through through July. So no update there. It will still be the same hours, Monday, Wednesday, Friday. I know that many of you have probably heard at this point that the health department will also be offering some testing. We have been working very closely with them to allow them to use our drive-through on the day that we're not using it. So likely that will happen on Tuesday evenings. Access Health also has offered to staff it on the alternative weeks that the health department won't. So Tuesday evenings, I think it's 4 to 7. They're still cleaning up their details, but there will be community-wide testing. So those are people who are asymptomatic or have no reason to be tested for COVID other than they want a screening. So again, that will be the health department and Access. I believe right now it'll be every Tuesday based on the switching. So they'll each do it every other week.
Carrie, Carrie, quick question.
Sorry.
Yeah, no problem. This
Sure.
is Tom. If we see a spike in regional cases, will we reassess that that July closure date?
Yeah, absolutely. And I don't plan to close it in August unless, we're seeing 4 tests a week or something where it significantly decrease. Right now, we do have a provider out there, and that's just based on, orders and making sure that we're testing the right people. So we do have to be kind of cautious about, keeping that open in August, September, October, just based on volume. The provider out there is Pam Clark, and she is going to start seeing patients on Tuesdays and Thursdays. She is our pain management provider. So I believe that she will be extremely busy really fast. And so in order to kind of balance that, we're rotating other providers through there. But again, that's a significant cost if we're not seeing a huge community benefit. So we will reassess that for August, September, October. I honestly think with the predictions that we'll have to open it back up in the winter based on the COVID predictions that we'll have another round and spike, and we will need some testing at that point again. I'm not saying that we will close it August, September, October, but I am, saying that is a potential if we see a significant drop off, number one, of countywide cases, number two, of people coming to be tested.
Thank you.
Sure. So another update on Facebook Live, we have decided after, I believe, next week that we will discontinue Facebook Live for the immediate future. Obviously, if there is a rise in cases or COVID does follow the predictions that it will return in abundance in November, December flu season. Of course, that will resume immediately, and we'll start providing direct contact for face-to-face with the community at that time. And just to go over the other pieces that are on here, the primary care providers as well as specialty are transitioning back to regular office visits. So we're seeing an increase of the amount of people that we're seeing on site. Again, we have strict screening criteria at the front door, which could transition to the front desk. But right now, we are taking the temperatures of everyone who enters the building. We're asking the questions if they've been exposed or if they have any symptoms. And then right now we don't have a visitor allowance. So we're kind of screening those patients and reminding them about the visitor policy at the front door. Again, we are also talking to our patients about safer at home, especially those that are most vulnerable. So we're still doing a lot of virtual and telemedicine as far as the really vulnerable population that we have. We have seen almost all of the clinic employees. I believe I still have 6 that are off site, but most of them have returned because they are in either individual offices or large open areas that don't require them to be in a small space with multiple people. So that was one of our really strict requirements for coming back. So we are doing a lot of shifting of people, moving around offices to accommodate that and make sure that we're protecting our staff as much as we can with the physical distancing. Karen talked about elective procedures. We did return to that. We are seeing a great uptick in that. Our providers, of course, are happy with that. And again, we haven't seen an uptick in the COVID positive population coming for elective procedures. At this point, Karen, and I think we could verify that we haven't had anyone test positive prior to a procedure or surgery at the hospital. The last piece is the Mancus Clinic. We've had a lot of questions about the Mancus Clinic, so I decided, made kind of an executive decision to reach out to every single one of the Mancus patients. We do have 1,788 patients that consider Mancus their primary care home. So we sent out 1,788 letters to everyone to let them know that we are returning to the Mancus location on 7/6. All 3 providers will return. We will see patients in a different manner. We will have signage, they will call, we will screen them in the car prior to coming in because we really do have a tight waiting room there and we don't want anyone sitting in the waiting room. Our staff there will be protected with masks. We do have one area where we'll have 2 people sitting in a smaller space so that they will have to wear masks all day, and they have agreed to do that and are happy to do that to return to Mancus. The letter did also inform all those patients that we know there is a rumor that the Mancus Clinic is closing, and that rumor is not true. And it also encouraged them to call the office to schedule their follow-ups and their annual visits. I believe that's all I have. As far as COVID, did we want to talk about the financial or are we going to continue talking about operations and I can go into recruitment, or would you like to address the rest of this piece?
I think, Carrie, I think you're up a little bit later after we get through the finances on your actual medical group report.
Okay, fantastic. Thank you. I couldn't see it, so.
All right. I think that's it on the COVID part, unless anyone has any questions.
I have nothing. Anybody else? Okay. All right, on to quality. Are we locked up here?
Karen, are you on?
Oh, sorry, I hit mute twice.
Okay.
Bridget, can you pull up the next slide and we'll go for the CHC report? So there were several things that I wanted to go over specifically from the CHC report. The first one was severe sepsis. We had started working on this in the fall. We had implemented one process before the COVID started, and you can see we did improve from 0% to 40%. Then in January and February, we dropped off. Now, sepsis is an interesting thing. You either meet the criteria or you don't, and there's probably 26 elements that you have to meet. And one of the things we found out is when you transfer a patient from the ED to the inpatient side, we actually discharge them from the ED and get a new FIN number. So we created a form where we could do a handoff, and that way the nurses on the other side will know what is left to be done, because it's very time sensitive for that piece. So we just picked up our sepsis protocols again and are starting to work to improve those numbers. One of the next areas that I wanted to look at was falls. Now, falls are based on inpatient falls per 1,000 patient days. And so I'll tell you that we had 5 falls in July, September. We had 2 falls December, January, and then 2 falls January, March. So what we found out was that when we did our root cause with that is that the beds have a bed alarm on them. However, they were not connected to the nurse call system. And so with the way the floor is laid out, that presents a problem if the patient on one end, the bed alarm goes off and all the staff is on the other end taking care of patients, they may not hear it. And so what we did was we got cords to connect it to the call system. So now if a person tries to exit the bed, it alarms in the nurse call and you can hear it anywhere. So we'll see improvements on that as well. The next piece is the HCAHPS scores. Now this is the hospital rating. So remember, if a patient rates us as a 9 or 10, we get a point for it. If they don't, then we get basically a 0. So we did see some improvement. But some of the things that we're implementing, we changed our leadership roles slightly on the inpatient side. So now Megan Hickman is the director of the inpatient side and Janet's the clinical coordinator. So some of the things that we're going to be implementing is we're changing up our whiteboards in the rooms to help to indicate to the patient what's going on, as well as nurse leader rounding. We're going to improve our bedside shift report and hourly rounding. So we should see those improve just from implementing those 4 tactics. And I believe from here, Lisa would like to share, if you don't have any questions for me, some of the new elements that we've added to our quality program using a device called Syntact. Lisa?
Yeah, hi everybody. I think Bridget will be pulling up my PowerPoint here in just a moment, but I did want to bring to point, I've talked about Syntact briefly in the past, but this is the quality rounding tool that I've used to look at metrics and really drill down on areas that need improvement. The main thing for what we've been doing is we built chart review forms within this program, and those have been specific to nursing charting and areas that we really wanted to improve metrics on, such as blood administration, epidural charting, moderate sedation, pain assessment with giving narcotics and what we're doing after, and then restraint use, and then the quality chart review as a whole of making sure we have H&Ps and discharge notes and informed consent. So all of these encompass a very big piece to what is really required from a nursing standpoint. The second part, it's on my PowerPoint as far as an Excel spreadsheet with reports from clinical department chart reviews. This really broke out, the data that's entered into the Syntact can really pull back out on areas, how we're doing, what specifically we need to work on. And this report is just high level, but specifically for blood administration chart review. You can see May, we had our initial report, and then June. So it really didn't show the improvement that we wanted to see. We were compliant at 75% in May and then 74% in June. So we're taking that back to the nurses on specifics of, this is really drilling down to our vital signs done at 15 minutes for blood. So all of those components that are required for blood administration, but this actually can drill down back to the specifics and educate back to the nurse of what's required of them. So this is really data that can really show what we need to improve on. You can see the restraint use was at 55% in May, and then we moved up to 94. So ongoing tracking will be done with this program to really look at those metrics for quality and make sure we're improving where we need to be improving upon.
So Lisa, I want to jump in here too and say, these are the same that we do with sepsis. You either meet 100% of the entries or you don't, and it's either a pass or fail basically. And then the other thing that we set up for this is that when we do find an error in the documentation piece, we have this form that we send out to the nurse, and it shows exactly the VIN number, the patient that it happened on, as well as what was missed in the documentation, because we really want to create a new habit for them not to miss those things. And so that's the process by which we give it back to the staff to correct or to learn from that.
Correct. Yep. And we're also able to track Infintech, you know, those document review forms and the improvement for each specific nurse. And then just a high level pharmacy, they do a medication rec with the patient. So we added this survey into it to really see, you know, how well we're doing as far as patients and their education level for medications. That was an area within our HCAPs that was found to be an area of improvement. So you can see for June, the proficient is actually 41 questions, where 3 questions were falling out of what needed to happen. So the compliance is high, but again, for the deficient answers, it shows where maybe we need to be educating more on discharge for medication. So really breaking that down to the lowest level of what specifically we need to work on, and not say we're doing a great job, however, we're still missing these components, and we still want to look at that completely. So this is really just a high-level overview of this program, but really wanted you guys to be aware of what's going on and starting to really drill down to, you know, the very important specifics of what's needed for patient care. And, you know, I definitely give a shout out to staff, because they're very involved with this and, you know, very on board with getting this done. So have enjoyed working with everybody as a great team. And that's all I have, unless anybody has questions.
I don't have any. Anyone else?
Okay, thank you.
Thank you.
Thanks,
I would
Karen.
say that was a quality report.
Well said. All right. All right, back to Rick, I believe. Yeah, back on to Rick. We already discussed, obviously, the Blue and Company audit, and we'll have to approve that at some point, but or after the.
Tom, if y'all want to do a motion now for the audit, that'd be great.
Okay, do I hear a motion to approve the 2019 audit?
I so move.
Is there a second?
Second.
I second. All right, I'm not sure who approved the motion. Was that Susan or was that?
Susan.
I seconded.
Okay. Okay. All those in favor?
Aye.
Any opposed? No. Bridget, did you get all that?
Yep, I got it.
Okay, all right, thank you. All right, Rick.
Thanks, Tom. May was a good year, and I'll keep it brief. Again, we had strong patient cash collection, close to $4 million. We did see some stimulus money of about 4.5, and some grants, and then a small donation. We're clicking along. Our net AR increased by about $450,000, and non-patient AR decreased by about $4. Inventory, we had a slight increase of about $2,000. We're still keeping a lot of things. We still have a lot of PPE on site. Our goal is to get it close to 5 months, and we've got a plan in place with Ethan Schwartz dealing with that. Fixed assets, again, it did decrease primarily due to the depreciation expense, as Steve kind of inferred in the the audit report. So our depreciation expense runs anywhere from about around $370,000 to $380,000 a month. Liabilities, again, we decreased accounts payable to about $1.4 million. Payroll liabilities went up with the last couple of days of the month to accrue. We are prepared for July. We do have 3 payroll payouts in July, so you'll probably see a hidden cash of about close to $1 million on that, more than we in payroll than we pay out when we have 2 payroll months. Work through the ambulance rebuild project, and that's going well, it's positive from a cost report standpoint as well. Again, great things happened in May with stimulus money of about $4.5 million. So revenue over expense for May was $3 million, which brought our year-to-date number up to 1.2. The earnings before interest, depreciation, amortization for May was about $3.6 million, and year-to-date earnings before interest, depreciation, amortization improved about 3.7. Again, we had a strong income statement. We were probably about 85% of volumes and revenues. We kind of closed the gap on that, but total net revenue was about $3 million greater than budget, and that was a result of the stimulus grants. Provider salaries and staff salaries, again, we had made some accruals with respect to that. Our contract labor did go down, which are people that are agency folks, and based on some of our nursing needs, things like that, we didn't need as much as we did as in the past. Benefits were slightly above budget by about $134,000. Again, and this leads to the fact that we self-insure up to $200,000, and that's when reinsurance kicks in. You're going to see benefits maybe run slightly high. Everything else was pretty well in range. Our interest expense was with our normal budget of $143,000, which the bond interest on the debt is about $137,000 to get, and the depreciation was $375,000. The donations resulted from the MCHD sales tax and such. So any questions on our narrative?
I've got nothing.
Okay. Our narrative was prepared upon review of our balance sheet and our income statement, which are on the following 2 pages. Again, the next schedule on page 37 of financial packet shows what is derived from the MCHD sales tax plus what we pay. Pretty self-explanatory there. Again, days cash on hand as of April were 106. Right now we're at about 119 days cash on hand, and we're at June 24th. So strong cash from collections and cash management. Again, statistically speaking, we were, in most instances, about 75 to 85% of our stats, and we kind of eased back into physical therapy and so forth. So that's why it's around 75%. We do have our ratios, which put us into our forbearance, which is on our next page. So we're clean from that standpoint on page 40. We also show cash flows where we have cash balance per balance sheet, which was strong. And then here's our scorecard, CHC, our business office metrics and such. So we're within where we need to be. I don't really have anything else, and want to open it up for questions that you guys may have. I do know there's a CHC invoice that you guys need to discuss and approve, and then the financial statement presentation.
Yep. Are there any questions about what Rick just reported? And I know that finance committee, and I didn't make it last week, but finance committee, I believe, approved the May financials as well as the recommended the payment of recommended the approval of the financials and the invoice. Any questions about that, or is there anything I missed, Dan, from last week's financial meeting?
No, we approved all that.
Okay. Okay, then I'm gonna see, then I'll make, is there a motion to approve the May financials?
So move.
Is there a second?
I'll second.
Okay, all those in favor?
Aye.
Okay,
Aye.
Aye.
none opposed? All right, how about the CHC invoice? Any questions about that? Do I hear a motion to approve the CHC invoice?
I'll make a motion.
Is there a second?
A second.
Shirley seconded. All those in favor?
Aye.
Aye.
Any opposed? Okay, all right. Rick, thank you. Rick, thanks. Welcome back to Colorado too, Rick.
Thank you. It's good to be back.
Right on. Okay, let's move on to Carrie.
Okay, so I think the only thing that I have is a recruitment update. We have two providers that are in the recruitment pipeline. One of those providers is Wendy Stevens. She is a nurse practitioner. Background is hospitalist, and she has worked outpatient wounds in Taos for the last couple of years. She will be joining us August 24th. So that will allow us to transition our wounds from the hospital side to the clinic side. So we will have an official outpatient wound clinic located in the rural health clinic. So it will be upstairs in the MOB building. We will provide outpatient care to all of our community with who have wounds or non-healing wounds. She also has an additional skill set of placing central lines and peripheral catheters. So she has, again, an additional asset to bring to us for those that need long-term antibiotics. That we are currently using a third party provider. So we're using Durango Radiology to place those lines in our patient right now. So she will be able to assist with that, as well as be the primary provider in the wound clinic as we transition it to outpatient. The second provider is Mariah Tarpey. She is a pediatrician who will be joining us for 2 days a week. She will also take 5 days of call a month, which is a huge help to our two providers, or two in-house providers, and also Dr. Barkhurst, who do take pediatric calls. So we are very thankful for that. Her start date is still a little bit in limbo, but it will be in September at some point. Her husband and herself, Jeff Tarpey, is a hospitalist that we are bringing on board as well. And so they are making a move from Washington State back to the Four Corners area. Originally, they were located in Montrose, Grand Junction area, and then moved to Washington, and now are coming back. So again, that will be a huge addition to our team, and we are really excited to have them join. The last piece of recruitment that I want to talk about is the OBGYN recruitment. We do have an interview tomorrow night. All those interviews, of course, I include Dr. Smith and also Dr. Schmidt, who are our primary OB providers for the hospital system and for our clinics. So we are interviewing tomorrow night. We do have a couple candidates lined up to interview, I believe 2. The first one is tomorrow night, like I said. So hopefully we'll have some movement on that. We really do need an OBGYN provider, so we can provide even better care and more care here in this area. I do believe we could capture a lot more patients and provide our community with the ability to get in faster to see somebody for OBGYN services if we do add this provider. So we're, again, hopeful that one of our interviews works out, and we will have an update at the next board meeting. And that's all I have for recruitment at this time.
Strong work, Carrie.
Thank you.
Is it difficult in this atmosphere, in this environment to get people to move?
You know, we kind of laugh because it's funny, you know, people that are interested in rural medicine, and Dr. Smith and I just talked about this today. You know, if they're thinking rural medicine, they could be in Indiana, or they could be in, you know, the middle of South Dakota nowhere, or you could be in some place like the Four Corners where you have access to all these amazing things. It's just, how do we get that out to people? And, you know, part of that is partnering with the recruiting company that we have partnered with, Jackson Recruiting, to try to kind of gather that group of people. It's been extremely difficult to recruit for this area, which is just, you know, seems insane. If you're interested in rural medicine, you know, you would think that this would be one of the areas that you'd want to access, because you're also really close to, you know, any area that you would want to go to. So you could go to Denver, you could hit Salt Lake, you could hit Phoenix. You have all the major airports around, but you also have, you know, the seclusion and all the outdoor activities that we have. So really, we are trying to get somebody that is most interested in the area, and then work with them from there. So our recruiting company has been told that I've spoken with them several times over the last 2 weeks, that my priority is that they know the area and want to be here before we interview them. They understand the dynamics of our population, and that they understand, obviously they are interested in rural medicine or we wouldn't be interviewing them, but they also understand what Cortez has that other areas for rural medicine do not have.
Thank you.
Yeah, of course.
Okay.
That's it. I don't have anything else.
Okay, cool. All right, well, thanks, and make sure your staff knows that we appreciate all that hard work. Okay.
Absolutely.
Okay. All right, Tony, on to you, man.
Yeah, really not a whole lot left. As you figured out, I've gotten very good at delegating these reports, so it works out well for me. But I guess the big thing for the month is I've managed to stay out of the public light. I don't think I've been on any public videos at this point, so that was a good month anyway. I think there was a radio interview, but it was pretty uneventful. So, like I said, other than
And
that,
you look good on radio, so that's good.
I said I had a face for radio. Yeah, everything actually is really going well. Like I said, I'm pretty pleased with where we're going right now, but really don't have anything other. There was one thing in the facilities committee, and just a little background on this is what this one particular project would fall within my approval anyway. But one thing I stressed to the facilities committee, and I want to make sure everybody keeps on track with, that the facilities committee it can make all the recommendations that they feel and they need to make, but ultimately everything has to be approved by SHS and the SHS board. And I want to make sure everybody stays on that track, that they can't spend our money without the board's approval. And we just need to make sure we keep that out in front of everyone. And that was really the point of bringing this back to the board, is everybody didn't lose track of that. We do have a lot of things we need to do, a lot of money that needs to be spent, but it has to be done within the constraints of the budget of SHS. And we want to make sure we do that as we continue to move forward. So, any questions on that at all?
No, but I think if we can get that SSR report, the revised one, to the board, that'll give everybody an idea of where we are. We could discuss that again next month.
I think that's going to be really important. And one thing that you're going to see on that is a lot of things have been removed because we are doing things. We're doing a lot as we move through this, and we're hitting some of the things that's already on the report that's being done that we've within our capability, or things that are breaking. We're just going ahead and doing them. It's not like we're sitting back and just letting things fall apart. We're keeping on top of it the best that we can. So and certainly are tracking that as we do it, what we're actually spending. So, but yeah, I agree. I think it's time to get for the board, as we do have new board members, and everyone to get a good idea of where we actually stand on that, and a true understanding and appreciation of just what the dollars needed to do that's going to be.
Yeah, it'd be good, and hopefully next month, I guess we have that before the next NCHB meeting, and maybe that's something that we could highlight with them.
Right. And, okay.
I'll try and make it to that meeting next month rather than do it virtually, if possible. So, okay. Anything else, Tony?
Not that I can think of, unless anybody has any questions for me.
Any questions? Okay.
No, just wanted to continue to say thanks to you guys. I'm impressed every day that we continue to make it as far as we do as an organization. So I'm proud to be a part of it, and proud to work here. So.
Okay.
Well, thank you very much. I do appreciate that. We have, I will say, we have an excellent team that is, I think, as Steve said, they're doing things that you just don't see happen in an organization like this, and it's certainly good to be a part of it right now.
Good. All right. Before we go into executive session, we need to approve the May minutes. Any questions or edits of the May minutes? Okay. Do I hear a motion to approve the May 2020 minutes?
So moved.
Move.
Is there a
I'll second.
All right, all those in favor?
Aye.
Aye. Okay. All right, we're going to adjourn into executive session. Does anybody need a break for 5 minutes or so?
I'm good to continue.
Okay.
It's going to take me just a minute to get the next section set up. So if you can give me 3, that would be great.
Okay, before we break, so we're gonna leave this Zoom meeting and call in. Is that our plan?
Yes, the link that I sent with your executive session packet.
Yeah. And then is there a video link on that? I can't remember.
Yes.
Okay.